Dear colleagues, those are two cases of PC rent in which I was trying to place the IOL inside the bag. In this first case, it's like a horseshoe tear. You can see it close to the middle of the posterior capsule, and I also have a small cortical remnants left at 1 o'clock area, which I will take out after the IOL implantation. So I'm trying to grab that flap after injecting the viscoelastic inside the chamber and try to make a round rhexis. The flap is getting teared, but I still have a small tag which in the event that I will make some pressure during the IOL implantation, that will round towards periphery, which is not something that I would like. So that's why I'm keep trying to get that tag and complete the posterior capsular rhexis in order to have more stability in this capsular rhexis on the back capsule of this. So after a couple of attempts, I get that tag and complete the round posterior capsular rhexis. Inject a little bit more the viscoelastic to make sure the capsular rhexis is completed, and injecting the IOL. I prefer to inject the IOL first on top of the bag, and then with the Grisauer forceps 25 gauge manipulate the haptics inside the bag for more control. I think I have more control over this procedure if I'm doing this way and not straight up injecting the IOL inside the bag from the injector. Rotating the IOL into the position and having the trailing haptic also inside the bag, and then with an aspiration needle assisted by infusion cannula, I clean up the cortical remnants that I still have left at 1 o'clock and clean the anterior chamber of any viscoelastic. And at the end of the procedure, I place some myocol inside the anterior chamber to bring the pupil down. On this second case, you can see the tear is pretty wide. It's going from 7 o'clock to 2 o'clock. So in this case, I cannot perform a posterior capsular rhexis, but I still want to place this IOL single piece inside the bag, and again injecting the IOL on top of the bag and using Grisauer forceps. I'm trying to place the haptics 90 degrees away from the tear in order to achieve more stability inside the bag. Getting the haptic. Notice the fact that I don't hold the haptic with the Grisauer forceps right at the junction, but a little bit away from that. I think that's the best place to have that manipulated inside the bag. And then for the trailing haptic, I use the chopper to tease the haptic inside the bag underneath the anterior capsular rhexis. And as you can see, the IOL it's 90 degrees away from the posterior capsular tear. At the end of this case also I clean up the anterior chamber from viscoelastic, place some alcohol to bring the pupil down and constrict the pupil, and then check the with the diluted triamcinolone if there are any strands of vitreous inside the anterior chamber, but there are not, because I was checking that before injecting the IOL. So that's the end of the case. I hope this will help you in your practice also. Thank you for your attention.